Okay, so I think it's a good idea to start. Yeah, other people can always join in later. So good morning, everybody. Thank you for joining us and welcome to today's session called COVID-19 Accelerated Digital Transformation. What's next? I'm Bob Verbrugge. I'm a Business Development Manager eHealth at Comarch Benelux, and I'll be your host for the next hour. I'd like to briefly introduce our speakers for today. So we try to bring different stakeholders to the table, and I really think that we succeeded in this. First, we have two speakers who will give a joint presentation, both from patient and hospital perspective. On the one hand, we have Valerie Storms. She's a patient engagement manager at Roche Belux, and also co-founder and member of the Patiëntenambassade at Hasselt University. But at the same time, she is also a patient representative at Cystic Fibrosis Europe and a member of the executive committee of the European Cystic Fibrosis Society Patient Registry. On the other hand, we also have Professor Dr. Noppen, whose track record is too long to mention everything, but you can know him as the CEO of University Hospital of Brussels. And last year, he was also elected as Health Personality of the Year in Belgium. And then last but not least, for the second part of our webinar, we have Kazimierz Cięciak, who is Consulting and Product Management Director at Comarch Healthcare. Before joining Comarch, Kazimierz worked for 18 years at University Hospital of Krakow, where he dealt with streamlining logistic processes and property supervision. And he will bring to you the industry perspective today. After presentation, there will be a short Q&A session. So if you have any questions, please ask them in the chat. And at the end of the webinar, we will ask them to our panel, and they will do their best, or they will try to answer those questions. I want to let you know that the session will be recorded and will be available after the webinar. You will receive a link through email. So yeah, I can imagine that most of you are not watching for me today, so I will stop talking now. And for those who are just joining now, welcome, and I leave the floor to Valerie Storms and Professor Marc Noppen. I will share their presentation. Yes.
Okay. Thank you, Bob, and thank you for the kind invitation and for the opportunity to give this very special lecture, because it's the first time that we do a joint presentation, me being a doctor and even a pulmonologist, currently serving as the CEO of the University Hospital in Brussels, together with Valerie, who is a patient and a cystic fibrosis patient, which is mainly a lung affection. And she has been treated for many years now in my hospital. So there's some lines of coincidence working here. We've only met a few years ago at the hackathon, because we are also both very interested in the future of healthcare and in the digital enablers which can shape the future of this healthcare. It was Valerie who suggested, because we were both invited for giving a speech, to do this together. And I think this was a marvelous idea, and I really am very, very glad that we can do it. And I think we might be trendsetters here, Valerie, because I cannot imagine talking about the future of healthcare anymore without the active involvement of a patient. And this is something we have forgotten too long. But to get started, some words about the impact of this pandemic and how we manage this as a society, but also as a healthcare organization, as a hospital. This is an important slide. It shows you at every peak of the COVID that we have witnessed the past 2 years, and we have witnessed 5 peaks for the moment. But actually, such single peak is in fact 4 peaks, is in fact 4 events. There is, of course, the acute inflow of ill patients in the hospital. There's a second peak somewhat later, which is the postponed non-COVID pathology that will come back to the hospital at a certain moment and that you have to catch up. There is a third peak, which is the interruption, the effect of the interruption of chronic care, patients with chronic diseases. They will also stack up and you will have to treat them. And then there is a fourth very important wave, which is often forgotten, and that is the mental impact of a pandemic on society, but also on the co-workers and on the people working in the hospital and on the patients. And actually, these events, we have witnessed these events for five times now in a period of 2 years. And there is a very important consequence of this, is that the personnel didn't have any rest point. Society did. After this, you always have a peak, and then you have this descent of number of cases. But for the people working in the healthcare sector, it's actually a flat line, and it's something that we shouldn't forget. And I'll show you why, how we tackled this challenge. The first thing we did in the acute phase is go into crisis management. There's which is the simplest form of management. A hospital normally is a very complex environment with a very complicated hierarchy. We switched the governance to this simple scheme with one central command unit and 5 departments. Normally we have 41 medical departments and 16 non-medical departments and a number of layers. We forgot that. It has to be governance based on trust and based on speed. And that is the most important in crisis management. And there's only 3 rules to remember: unity of command, unity of execution, and unity of communication. I'll go very quickly to these five working groups. One was the medical one, and that was the separation of the hospital into a COVID and a non-COVID zone. That is easier said than done, because you have to separate everything, meaning the emergency, the ICU, the medium care, the wards, the operating theater, delivery rooms, children's hospital, etc., etc. You always have to double these environments, and you have to make sure that there is as little connection as possible. We had to upscale the critical care capacity. We had doubled the ICU and medium care beds overnight. This has been done in weekends, and a number of wards were reserved for COVID patients. The second working group was our army, which is the nursing army, 1,500 people. And they had to switch jobs overnight also, had to change teams, had to have crash courses, had to have new assignments, and other ones were without any job, because you remember that the polyclinics were closed at a certain moment. So you have a number of people who are sitting there and doing nothing between brackets. I'll come back to that. I'm very much, I was very glad that Time magazine in 2020 called the healthcare workers, the medical workers, Person of the Year. And they really deserve this. These frontline workers, they've worked really, really, really hard. And as I told you, now for 2 years in a row. The third working group was our HR department, which had to manage all these new assignments, contract changes. We had to follow up the COVID positivity of our own personnel. We had to manage at a certain moment 1,200 volunteers in our hospital and our campus. So this also a very important group. And I'll show you some images. I'll go very quickly to this. The hospital was closed for visitors, but we had, for instance, a number of volunteer students of the medical faculty. The university was closed also, as you might recall. And so they delivered books, etc., to patients because they couldn't receive any visitors. This is me and some very happy faces. These are the medical students who really volunteered in very large number to support also the medical functions in our hospital, the screening of patients, testing of patients, etc. This was a nightmare group, materials and logistics. You might remember that at a certain point there were not enough masks and gowns, etc. The borders were closed. Our suppliers couldn't supply the necessary goods, etc. So luckily we managed this quite well, and we even could support our neighboring hospitals. And so these people were certainly not technically unemployed, because they had to really figure out how to be able to support the medical services. And I'll show you this because as I told you, some personnel was out of work, but I refused to call upon the technical unemployability, which was possible at that time, because I'm still convinced that you have to do this as a team, 4,000 people. Everybody has a role. And since we didn't have enough masks and gowns and protective gear, they organized themselves into an atelier and they made just stuff themselves. And we could deliver that to our surrounding hospitals. And the fifth group was busy with all the rest. So one of the topics of today, of course, is IT and the digital transformation. And COVID-19 was certainly an accelerator or a catalyst factor of a very fast development of a few things. This graph is illegible for you, but it just shows you that normal activities went down to about 50% of normal, whereas teleconsultations, which we didn't do at all before, really hit the floor and were within 2 weeks were organized, and we went up to 2,000 teleconsultations per day. The same for home working, which was not really so new. We had before COVID between 100 and 140 people who were working at home already. But during COVID, we went to 1,200 personnel per day. And now we just kept this in a very smart way, we think, because this is the new kind of working. Even when the government doesn't impose it to us, we still have about 400 to 500 home workers per day. And they are very happy. We follow it up. We give the necessary equipment. We invest in management and leadership and a new type of organization. When a team is hybrid working at home or in the hospital, and we evaluate and we see that the results are actually very positive. And if I may be honest, 90% of the personnel, the work performance has increased as compared to pre-COVID. This fourth wave that I showed you, this large red curve with impact on the mental well-being of the personnel, was very important from day one. And we did more than 100 actions from day one onwards to support and to thank and to show respect to our co-workers, what they were doing. There was, if you may remember, during this first wave, especially, there was a lot of question marks. Nobody knew exactly what was going on, and so there was a lot of stress and a lot of anxiety. And just a very few examples. Public transportation was at a certain moment reduced to 50% of normal, and so a number of nurses couldn't get to the hospital. So from Cambio, we received 100 cars just to be able for our nurses to transport. We shared good news. The first patient in Belgium who got off the respirator was, by coincidence, at our ICU. So we share this good news. At our campus, we have Villa Samson, which is a charity-sponsored place where patients can receive their pets, animals, and where we do animal therapy. Well, it was closed during COVID, but we made a Villa Resilience out of it instead of Villa Samson, where there was an emergency team accepting patients with stress and to relax, etc., etc. So more than 100 actions were installed, and some of them were keepers. Very small tokens of appreciation. For instance, every worker at the hospital got a personalized photo book with photos by Lieve Blankaert, who is a famous art photographer, and with some text from emails from patients sent to the hospital to thank the personnel. And these are very small gestures, but they make a world of difference. Free breakfast, free coffee. Once a week, I joined the kitchen team to make fries for the people who did the night shifts, etc. And currywurst, frieten and currywurst for the Flemish people. They understand what I'm saying. It's not very healthy, by the way, but in this crisis, it did a lot of good. We had fries night, we had pizza nights, etc., etc. The theaters in Brussels were closed, but yeah, okay, the artists were still there. So we helped them with COVID, and they came once a week to give a free podium for our personnel. And every Thursday, during the lunchtime. They gave performances, etc., which were very much welcomed by the patients. So I think one of the secrets of success in managing such a crisis as a hospital is to do it as a team. And that was our main purpose. Now, not only for the personnel, but also for the patients. I'll give you two small examples. At the left side, you see here this help desk. These were volunteers from our fertility clinic, which was closed during the COVID waves. And we installed a center where we called the families of all the patients who were in intensive care 3 times per day proactively to give a status report, because visits were forbidden. There were families and friends couldn't visit the patient. And so the impact of this on the patients was such that we have kept this after the COVID crisis. So we have installed a permanent telephone desk where we call upon the families of the patients. This costs money. This is not reimbursed, but the impact on the patient care was such that we kept this. And since there was no visitors allowed, we had telecom operators who gave us smartphones, and we had a lot of volunteers so that people could stay in contact with their family. So not only personnel delight, but also patient delight. Valerie?
Thank you, Marc. I can only agree that this connection between patients and family is crucial for their motivation to keep fighting for their health. And hi, everyone. So my name is Valerie, and today I will talk from my personal patient experience living with cystic fibrosis and diabetes. So to explain a bit the impact of the pandemic on me as a patient, I would like to start with giving you some context on what is cystic fibrosis, because it's a rare disease. There are only 75,000 patients worldwide living with cystic fibrosis, and it's caused by a genetic mutation. It's a progressive disease. There is no cure yet, and it impacts different organs, like you can see in the figure, where the lungs are the most life-threatening. It's a very complex disease, so it requires follow-up in a specialized multidisciplinary cystic fibrosis center. And for me, this is at the University Hospital of Brussels, so you see the link with Marc. And the main elements of my daily therapy are the intense physiotherapy sessions, as you can see in the right corner. This is my therapist, Hanneke, who helps me to keep my lungs clear by removing the very sticky mucus. It's a daily effort we have to do. And on the other side, you see the picture of my daily medicines. We also often need to go to hospital for IV antibiotic treatments. And then 30% of the patients also develop diabetes during their life. And for me, this was at the age of 20. So you can imagine that the intensity of follow-up and treatments and the day that the pandemic took over the healthcare resources, that this of course impacted our access to healthcare services and treatment for chronic patients compared to what we were used to. And especially now with the situation in Ukraine, where the treatment for cystic fibrosis was already less qualitative compared to Western Europe. I also want to highlight that I'm, as a patient, I'm very thankful that I can be treated in Belgium. But like I said, of course, we felt this interruption in the continuity of care. For example, the so important physiotherapy was completely unavailable during lockdown. Also, medical consultations, examinations were postponed. The pulmonologists who were my main caretakers, and the CF nurses, because they have so much expertise in lung diseases, they were transferred to the COVID ward. So your normal care team was not available. And what we saw as patients is this shift to teleconsultations, which make a lot of sense for certain aspects. But for physiotherapy, you can imagine that having it over the phone is impossible. Treatments and medicines stayed relatively available, especially in Belgium. This was not really an issue for me. But clinical trials and access to trial medicine, there was not really a remote solution. So we still had to go to to the hospital to do the tests and to have access to the treatments. So here you see that there were some first steps made towards telemedicine. It's a trend seen across Europe. I placed a picture of a survey that was done by CF Europe. It's the European Cystic Fibrosis Patient Organization. The survey was filled in by 900 patients and family members, and it shows that for 30% of the patients, online consultations were introduced with the start of the pandemic. Online prescriptions were already happening before the pandemic. Online education to support self-management of the disease was only available for a minority of patients. So although we are happy with this evolution towards hybrid and telecare, we need to be more ambitious for the future. We need to take it a step further and really digitally enhance the entire care pathway with integrated tools and services. Another aspect of the pandemic was, of course, the impact on the mental well-being. Also here, the survey of Cystic Fibrosis Europe showed that 56% of carers and 36% of patients really felt a high level of threat. There was a very high level of fear that treatments would become unavailable, and 2 out of 3 patients felt that this COVID situation would really be negative for their general well-being. These numbers, of course, say more than my personal story, but I can only confirm that I experienced also these high levels of fears and concerns. Fear to get COVID as a lung patient, fear that I had to be admitted to the hospital for my cystic fibrosis. I even canceled visits myself. I canceled my physiotherapy out of fear for infection. I was also really afraid that my medical, the medication that I received in my clinical trial would become unavailable, because this is kind of a lifeline for me at the moment. So with this said, as a patient, I see huge potential in home hospitalization and hybrid clinical trial designs, as this could really help to reduce fear for infection and improve patient safety and quality of life. However, this is not yet part of the routine care, so please let us make this possible in the future. A short side note, this is a picture of me at Ter Zake. It's on national television. I did this together with my patient friend Axel, where we were really raising the awareness on the importance of wearing masks to protect vulnerable people. At this moment, it seems already ages ago, because wearing a mask became so normal, but at that time, it wasn't. And we as patients, we really joined forces, and we wrote an opinion article why it is so important that we as patients can still be part of society, we can still go to work, and that other people help us by protecting us by wearing masks. And then the third item was the impact that I felt because there was kind of not enough relevant information for me as a patient, especially during the pandemic. So no guidelines on how to manage it, also not like work-related, family-related, access to healthcare, how you could protect yourself, and also no insights on what would be the impact of a COVID infection on cystic fibrosis. And this, of course, increased fear and concerns. So also here, I think there is more a need for fit-for-purpose communication tools between healthcare professionals and patients to keep the communication and the information, so that we need to refer less to Dr. Google. Of course, these were kind of my personal feelings, but when you look at the results of the European Patient Forum survey, you see that 95% of patients felt impacted, 49% mentioned this treatment delay, 65% mentioned this impact on mental well-being and this lack of information. So I would like to conclude with this slide for the impact, and back over to you, Marc, for how we see the future.
Okay, thank you, Valerie. Let's switch gears now. What we can learn from what we have learned during, what we can keep from what we have learned during the COVID pandemic and what the trends are that we see in shaping the future of healthcare. I think that just a few words which are important, I think, or a few principles which are important. I think most scholars and most practitioners who think about the future of healthcare acknowledge that there is a trend or a movement towards what we call an integrated healthcare. And there are some basic principles behind this. There's, of course, the value-based healthcare principles, which we know since Michael Porter and Thomas Lee's paper in 2013. And but it should be extended, I think, towards the integration of healthcare organization and delivery. And I'll come back to that. And this way we can achieve the famous quintuple aim of healthcare. You remember maybe the triple aim, the quadruple aim, and now there are 5 main aims for every healthcare system in the world. That is to try to find the best possible equilibrium between population, achieving the best possible population health, the best possible patient experience, and all this at an affordable cost. But not to forget the care, the well-being of the care team. And I showed you during the COVID crisis why this is so important. And then let's say the equity and inclusion criteria, which has joined the quintuple aim. This value-based healthcare, actually, it's more than words, but if you read carefully, what is this about? It is about achieving the best possible health outcomes that matter to patients. And this is the little sentence that is often forgotten, because people who are working as professionals in the healthcare sector, such as me, we tend to think from our viewpoint. And I think it's a reflex, and we have tried to introduce this in the working of our hospital, that we very frequently ask each other the question, all these things that we are thinking about and doing, is there one patient that will be better after this? And if we cannot answer it immediately, we just skip the project. So we should move away from this supply-driven, volume incentivized system towards a more patient-centered system organized around what patients need, and therefore shift the focus from volume and profitability. And this is the way we work today and why we are awarded, towards a system that allows for the best possible patient outcomes. It seems very logical and very trivial, but if you are in this, working in this system, as most of you are, you see that this is not the main driver. I'll skip this. And so we see a shift towards a volume-based, fee-for-service, volume-driven system towards a more outcome-based and value-driven system. And here, digital information can be a main lever, a main catalyst. And I will show you some examples of it. You have seen already the teleconsultations during the COVID. I'll skip this. And the second thing after value-based healthcare is the integration of care. And I'll just give you one short example. During COVID, when it came apparent that the GPs and the first line were really struggling with reorganizing themselves, and when the dramatic catastrophe in the elderly care residents came above the radar, we as a hospital, we connected towards the GP, the first line, and towards the elderly care resident homes. And we just made one team. We exchanged information, personnel, protective equipment, etc., etc. And so actually, in times of crisis, we were actually performing integrated healthcare. Nobody cared about the fees that could be charged, etc. We were just doing it. So for me, that is a very important lesson, that this is actually the way to go forward. And what might help us, we mentioned it already a few times, is the digital transformation that we see, and where we, even in this hospital, and it may sound counterintuitive as a hospital director, but I want to get all these patients out of my hospital. I don't want them in my hospital, to be very short. And it is like financial suicide in the current system. But for me, the ideal hospital is an empty hospital. It's where you have no patients. Of course, it's impossible. I know it. It's more a caricature. But this is the way that where digital can help us. And I give you again the floor, Valerie, to give us some examples of this.
Yes, Marc, and I think we are aligned there. Patients also want to get out of the hospital. And here I was sitting in the hospital during COVID, and I was alone in the waiting room. Like, it was such a strange image, because normally it's so crowded. Then I took a photograph for my family, and it was the reason I was there was because of this clinical trial that was not possible to remotely follow up. And I think there we need to make the shift, and like is shown by the arrows, that the part of a clinical trial that needs to be done on site will decrease in the future, and the home part will increase. And this is possible. There are technologies that can leverage this, and it will of course improve our experience as patients and our engagement in trials. It will increase enrollment and retention rates, but also the company will have much richer data sets of data in between visits, and studies are easier to scale, will cost less. So many advantages to make this transition. And you can see with COVID, the pandemic, it really raised the adoption of digital health technologies by companies to protect patients and to ensure continuity. And it's super exciting to see what is already possible, going from wearable ECG monitoring towards remote vision tracking, towards EEG technology to do it remotely. So really great to see these technical evolutions, and hopefully we can also implement and adopt them.
So this is actually symbolic for the fact that healthcare is becoming a software branch. You see here a picture of Wall Street in 1984 on the left, and you see a picture of Wall Street now. There's just a single person and a lot of screens now. But especially in the financial and the banking sector, you have seen this dramatic digital shift, which is now finding its way also in healthcare. This is an extreme example, the St. Joseph Mercy Virtual Hospital in Kansas in the United States. This is the first hospital without patients. There are no patient rooms, there are no consultation rooms. There is just a huge control center with people watching data coming in from remote monitoring of patients and doing consultations, etc. It's an extreme example, but if you look at UZ Brussels, we are starting to do similar things. This is still just about process control, and during COVID, when we were really submerged by patients, we had all these data, but now we made it usable and user friendly to see the bottlenecks in our systems. Where were the patients? What was the capacity of the intensive care, of the operating theater, of the emergency ward? Where were the patients, etc. So we were able to increase our efficiency between brackets with about 20%, just using the data that we already had. And this was just process control. On the medical field, there are more and more apps that are becoming available and who are slowly moving from the gadget level that they have been for a while towards really usable and usable apps with utility and value creation for the patient, especially in diabetes, Valerie.
Mm-hmm. Indeed. So as a diabetes patient, I'm kind of constantly using my smartphone and checking my blood glucose values that are measured by a sensor. It's just here on my upper arm. It's referred to this continuous glucose monitoring technology. The measurements are very accurate. You have one data point per minute. So you can imagine the amount of data and insights that this generates for doctors and patients to really optimize and personalize treatment and to support self-management of diabetes. And it will become even more powerful in the future if we can combine it with other types of data like context data, meals, insulin intake, genomics. So it's super exciting. And as a patient, it totally changed my quality of life. So also during the pandemic, we saw that the impact on type 1 diabetes was less severe than, for example, on diabetes type 2, where the sensor technology is not reimbursed. So we even saw, there was even evidence that the technology even improved the glucose control during the pandemic. So this is really great to see, and the discontinuity of care could really be prevented because the in-person visits were kind of replaced by these telephone consultations, but the doctors and the patients had these data as a backup to discuss treatment and care. However, a small side note, there is not yet this implementation yet of remote patient monitoring and surveillance. And so because there is no reimbursement for that and there is no legal framework and some clinical decision trees are lacking. But I hope in the future we can really go for the full implementation of this digital technology and really kind of leverage all the potential to personalize care, to reduce costs and so forth. So Marc, you have some data from the hospital?
Yes, to confirm what you said, that diabetes type 1 is such a typical example of where technology and usage of the modern technology goes faster than the legislation and the administrative necessary changes and legal frameworks, etc. And you see that if you look at 2019, the number of consultations that were done by our diabetologists, and you compare with the COVID years, and you see that thanks to the video and telephone conferencing, that was 0 in 2019, and now in the thousands still today in our hospital, that we were actually able, that you can see that there were even more patients under control during the COVID years than before. And this is one of the few examples and the few exceptions. And it is thanks to technology and thanks to an already mature technology, which is already widely used by type 1 diabetes patients.
Yes, and I'm really looking forward as a patient to the future of diabetes care, which will evolve towards this comprehensive and really connected virtual ecosystem where the information needs and the continuity of care will be covered, and also to the power of artificial intelligence and the huge amount of data that will personalize healthcare, but also predict events and prevent complications. So yeah, really excited about that.
Okay, and then you said the word AI, artificial intelligence. Is this really what is going to help us? Well, it will be one of the factors that will be supporting the new shape of healthcare, and that will be an enabler. And I'll give you one typical example is imaging, which is 100% digital for the moment. And there's always this fear, artificial intelligence will not replace radiologists. However, it will replace radiologists who don't use it. And to give you one example, in our hospital, we have 48 radiologists. And with the current number of images that we take, every radiologist has exactly 4 seconds per image, 24/24. So this is, humanly speaking, impossible. So here we are using already on a large scale machine learning and automated systems that skip out the normal images, so that the radiologist can focus on the abnormal images, which is what they are trained for. And there are other departments such as dermatology or pathology, where there's a lot of image-based medicine, where we see this trend already. And during COVID, for instance, we have developed, together with engineers of our Faculty of Engineering and with the spin-off company, an algorithm based on the CT scans of COVID patients. And this system, thanks to active machine learning and annotated data, was able not only to give you with a very high accuracy the exact diagnosis, whether it was COVID pathology or not, but also give decision support and give predictions. Showing an image, the system told the physician, this patient has COVID, will be on intensive care in 48 hours, will be intubated in 72 hours unless you do this and this and this. And this has been a dramatic aid in the clinical management of these patients. We did this open sourced, and it is now used in 800 hospitals worldwide.
Yes, Valerie? And I really like this collaborative projects. And in cystic fibrosis, we saw the same. With the start of the pandemic, all the CF centers across Europe start collecting and integrating data of CF patients with COVID. So there were 1,880 cases. And by pooling those data, we could really learn about the impact of COVID on CF. And we also had the scientific publication But the challenge here is how can we reach patients and families with this information? So that's also a challenge for the future. So as a kind of summary of our today presentation, I think that, or we at least like to make clear that we saw this huge need for digital support services and integrated services in the future to ensure sustainability, decrease fear and improve quality of life, and better communicate towards patients, and digital enabled pathways, more decentralization of healthcare towards patients' home environment, and communication platforms are three things that for me as a patient could really make the difference. And if I can conclude with a main message towards the audience, which I think are many people working in health innovation, like no innovation for patients without patients, because patients really have the experience of the total pathway, the clinical and the non-clinical, and we really feel the urgency to make the change for the better. And I also invite you to watch these two super nice examples of patient-driven innovation. It's the artificial pancreas created by Patient Ecosystem, and it's the Victoria 1.0 project collecting a huge amount of data around breast cancer and pathology. So over to you, Marc, for your conclusion.
Yes, this is a slide. Thank you, Valerie. This is a slide that I've used for a few years when talking about digital health and so forth and technological evolutions. This is something we should never forget. And this is something I remember as being a doctor, and which, thanks to you, Valerie, and the idea of doing this together has gained much more weight, I think, is that when everything else fails, just talk to the patients. Involve them. If we talk about patient empowerment and patient-centeredness and patient experience, etc., we still have the tendency to do it as healthcare professionals, and we have to really be convinced that the solution is often just in front of us if we only would ask the patient. And that is something that I've learned, Valerie, again, thanks to this collaboration. I have to thank you for this. And it is not without selfishness, because at some point, ladies and gentlemen, we all will become patients. And then we will be wondering why nobody is listening or has been listening to us. So I would like to conclude with this image, and thank you all for your attention. And Valerie, thank you for the nice collaboration.
Yeah, the same from my side, Marc.
Okay, thank you, Professor Noppen and Valerie. I think some valuable or good points were raised, and also some concrete examples were given, like, for example, with the diabetes case. Considering the time, I suggest that we immediately go to the next speaker, Kazimierz. If there are any questions, so please ask them in the chat. Valerie and Professor Noppen will be available after Kazimierz's presentation and are happy to answer those questions.
Thank you very much.
I give the floor to you. Yes.
Thank you very much. Yeah, I hope that you can hear me and you can see my presentation. So please confirm only. That's great. Yeah, so first of all, I would like to start with, great thank you to both of you, because this is something really important to have such a great impact to our activities as a company. And this is something that now we've got double confirmation that we are following the right path when we are talking about our healthcare activities. Very short about the agenda. So of course I will say where we are. Very shortly I will describe how we can imagine the future of the hospital. And when I'm saying we, this is not my only, I will say, imagination, but I've got the privilege to work with a great team, and we did really hard research, and we did a brainstorming session, and this is something that we can say something about the hospitals in the future. And of course, I will share also with you our approach as a company, because we are not only IT company, but we also got our own clinics, with remote monitoring center, with kind of central rooms with monitors. So this is something that we already got. So very short about the content where we are. So we already mentioned today. So the free beds for hospitals, this is something that we should achieve. So the safest and best place for patients, and I heard it from one of our professors in university hospital, is outside hospital. So that's why it would be great to have free beds in the hospitals. Of course, we have improved the efficiency and reduced cost. And these are the four most important, I will say, activities or the information that we've got. The aging population and the cost. And we are talking about aging population. This is not only the patients, but also medical professionals. So this is something that we are already affected with this, and we have to remember. Of course, pandemic, of course, patient centricity, I will be talking about it. And something that we've got, pretty new, this is the technology. I'm talking about pretty new because of the COVID, also because of something that the people, I will say, in my age are entering the healthcare system. We are able to use the technology in more advanced way. Now, something about the hospital in the future, and this is something for me really, really tricky, because I like this sentence from, probably Niels Bohr, that this is really hard to make the prediction, especially when we are talking about the future. But we did this brainstorming session research, and we've got some ideas. So first idea, and this is not only the idea, but a lot of confirmation, that hospitals should focus on something that is complex. Inside hospitals, we should make a specialization. We should be, I will say, ready to deliver care, what is needed inside hospital. Then, and today we already heard it more than twice, that the chronic disease management and different possibilities should be treated outside, so monitor remotely. And we also see and suggest that the trend, we can split different activity among smaller players that can help with access for the patient to get, for example, to radiology, to laboratory tests, consultation, and so on and so forth. And this, I will say, combining of these three elements can give us these outcomes that we would like to achieve. So, of course, improve the activities, free beds, reduce costs, and so on. Okay, and it is also the confirmation what we heard today, that we should aim to create connected hubs related to the healthcare. So, of course, hospital for the complex care, virtual hospitals for monitoring patients, then the different activities that can be done outside medical facilities, so the hospital facility. And in the middle, we should have and we should think about the patient. And this is something that it's the whole, I will say, new development of product software approach to the patient shows us that this is only one way that for now we can go. And here I will also give you some insight or share with you our thoughts about possible outcomes. What should we do? How can we go in which direction? First of all, we are talking about clinical outcomes, and here I will focus about only three major pillars. So decision-making tools, remote care solutions, and automation. It was already mentioned, but I would like to stress it that we should use the data, having such a, for example, possibility to analyze big data, to use the data that are already here. So I mean here saying in our electronic health record, in hospital data systems, in our wearable devices. So just having interoperability, that means that the data should be readable and understand in each hospital system, in each HRR platform in the same direction. Then we've got the remote care solutions, and we already discussed about it. I will try to go very shortly into details about the possibilities. and of course the personalized medicine, so the automation of the processes. So these three elements, very shortly about our approach as a Comarch Healthcare. So the platform that we've got that analyzes the data, gathers the data from different devices, simplest one, more complex one, and of course the remote medical care center that allows the data to be analyzed. And combining the existing devices, existing data to the remote platform, to the remote monitoring, we can achieve the results to improve the outcomes in the healthcare process. Giving also the kind of more comfort for the senior citizen, for the people that can be treated outside hospital. Also simple device like a bracelets with two-way voice communication with notification. We're gathering the data where the patient is, how can we help them. And even we know this from the experience, because more than 20,000 people already using this system. This is also so the calls implemented here, so the two-voice communication is really, really important for the patient. Of course, patient engagement application was Valerie was showing. This is the really important tool for the patient as well, and the solution that cover a lot amount of data. The cardiac solution, Comarch CardioVest, for a long time cardiac monitoring that is supported also by analytical platform with AI that provides the data for the medical professionals. So not only I will say a monk of data, but the key information. And of course, the telemedicine platform, the telemedicine software. These are these elements. And now shortly to the operational and financial outcomes that as a healthcare SINs should work also on it. So asset tracking. So this is something that was also mentioned by Professor. And this is important, that we should know where our asset is. And when we are talking about assets, so there are not only, I will say, medical devices, but very important assets of patients, and also very important assets medical professionals, making for example, the way shorter for all of key player in this field is very important. Again, supply chains was already mentioned today, getting the information automatically using data from electronic health record, from hospital information system. This is something that we, with digital command centers, can improve the efficiency of the whole ecosystem in healthcare. And of course, analyzing the data, business intelligence solutions. So this is the key three pillars of improving the financial and operational outcomes. And here again, the products that we as a company, as a group, implementing into healthcare system. So the asset tracking platform, the operation center. So here, for example, for now, the only operation centers that we've got, there are operation center in our medical facility. But this is something that we as a company have got experience running such a global operation centers for different projects. And improving the patient experience. So this is something that was mentioned today more times. The gateway for the patient entering the system. So the patient portal that he or she can contact the medical professional virtually, without face-to-face appointments, where we only have such a possibility. So this is not about replacing the face-to-face contact, but this is something when we are talking about improving and supporting the whole process. Patient application to collect the data, to not only collect information and the data from electronic health record system, from sensors, from telemedicine, but also with ability to share this information with medical doctor. medical professionals. And of course, mentioned before, the spaces, the places where we can perform our diagnostic remotely as well. And again, a few of our examples. So this is the application for the patient, health node application, where we cover the data, where we analyze the data, when we share the data with medical professionals. When we allow the navigation, we can make a video consultation with the medical professionals. So these are our approach, and these are our we hope impact, because our mission is the revolutionary approach with R and E. So not only with revolution, but also evolution approach to e-health. Thank you very much. 3 minutes before time, end of the webinar. So thank you for your attention.
Thank you, Kazimierz. Considering the time, I think if it's okay still for the speakers, that we still have some time for 2 or 3 questions that were asked in the chat. One of the questions that popped up a few times, it's and also a bit what Valerie already mentioned regarding reimbursement. What are your thoughts for you, Professor Noppen and Valerie and Kazimierz? What are your thoughts on financing? What are the hurdles? How are they tackling it in Belgium right now? If you can give your opinion on this and what should change, and what are the difficulties right now?
Maybe I will start with a little macro thought, and then we can drill down to maybe apps, etc. Most countries in the USO spend around 10% of their GDP on healthcare, except for the US of A, of course, who are a little bit crazy. But this means for Belgium more than 50 billion euros every year is spent in healthcare. That is a lot of money. And I'm convinced that this amount of money should be enough to tackle all the challenges, most of the challenges that come towards us. The question is, on what do we spend this money? And most studies that are performed on this show that I've lost you. Oops. Sorry.
We still hear you.
Yeah. There was a problem here. Most studies show that on average, probably around 20% of this budget is spent on what is called waste, and not necessary, unnecessary expenditure, administrative problems, redundancy, the wrong volume-based incentives, fraud, etc. So 20% of 50 billion is 10 billion per year. And I think this should suffice for the quickly evolving technology and pharma technology on orphan drugs and very expensive new technology to be financed. But this requires, I think, a very thorough and bold change of the way we spend our healthcare money. And the current minister in Belgium, at least, is starting this process, which will take 5 to 10 years probably. But I think there is enough money, but we spend it on the wrong things. And this is a very short statement, but I think there's a lot of truth in it. And I leave the floor to Valerie and Kazimierz.
Yeah, only +1, Marc. As a patient with a rare disease, it is indeed often a concern, what with innovation, new treatments, new technologies. So if we want to be able to afford this and make this accessible for patients, we need to make a shift and focus more on increasing efficiency and choosing for prevention. And there I see the potential of data and technology. So I hope this will be possible with the reform in the future.
I totally agree. So being in the business for more than 25 years already, and being an economist, so it will be, as a healthcare, we can always have, the money will not be more enough. But I totally agree that we should focus on the most important and we should spend the money in the right way, and it will be, I would say, from the perspective, it will be really important. Maybe something that I know that is already ongoing, but we have to stress it out, and we should always think about the prevention and patient involvement into staying healthy. It is something that will support the healthcare scene in general. Because if the patient will be not involved, not interested in supporting the medical professionals, supporting the healthcare in general, then we are lost already as a system. So we can't do it without our patient involvement. Thank you.
Okay, thank you for the answer. I think everybody is actually on the same line on this. I think we have time for one more question. I'm gonna take this question. Together with diabetes, what are to you priority chronic conditions for the implementation of integrated healthcare? So what are to you on the short term and maybe on the long term the disease areas also that are that would really benefit from digitalization?
Yeah, I think if I can start, diabetes was kind of an easy to start with, because you only need to control one parameter, and this is blood glucose. And based on this one parameter, you can make a huge impact on your disease management. While for other chronic conditions like heart failure, neurological conditions, often there are multiple parameters that you need to combine to manage the disease remotely. And there is this challenge. But we see, of course, that for other diseases, especially cardiology diseases where you already have these implantable devices collecting a lot of data, you see also this trend to go to non-implantable devices to manage cardiology diseases like, for example, heart failure, but also epilepsy, sleep disorders. So you see many disease areas where we are in the piloting and experimentation phase. And I think also there will go towards more sustainable implementation in the future.
I can maybe add a few things where you are talking about monitoring and follow-up, etc. There are more and more domains where we also have the hospital at home treatment areas that we are developing. To give you a few examples, we have now 1/3 of our dialysis patients are dialyzed at home. They don't have to come anymore 2 times or 3 times a week to the hospital. That's one example. But then you need, of course, a good follow-up of the body weight and the urine production, etc. A second disease area is, for instance, patients with pain pumps who have GABA or opiates in their pump system. They had to come to the hospital every month or so to have a refill and a control. But due to COVID, they had to stay at home. So what did we do? We developed a hospital at home team. So now we treat those patients at home. We are not reimbursed for that, so it's costing us money. But the patient satisfaction and the patient safety, and we did it in a pilot study, and now we are continuing it. It was 100%. So not a single patient wants to return to the old system. And that's what I said, that developments and new ideas often go quicker than the system can follow. Because getting reimbursement of this will take probably 4 to 5 years. But then again, we will continue to doing it. Another and a final example maybe is comprehensive wound care for very complex skin wounds, very often in vascular insufficient patients, and sometimes diabetes patients. And now we are doing this almost the 100% at home with specialized nursing teams and vascular surgeons and dermatologists. So these are new trends, and this is what, like Kazimierz showed, to get these treatments out of the hospital and to have this as much as possible in the close vicinity of the patient, and if it's possible at home. And these are trends that are really happening and probably will only increase.
So my short summary, maybe last one sentence. This is great that we've got here 3 approaches. So the clinician approach, patient approach, and business approach, and we are following the same direction. So for me, it means that we are on the right way, and it is optimistic for me.
Exactly.
Yeah, I think that was a great closure, Kazimierz. Okay, I want to thank everybody, and especially Professor Noppen, Valerie, and Kazimierz for making time and to share your invites, your thoughts today. I wish everybody a pleasant day, and thank you for joining. Everybody, if you want to revisit this webinar, you will receive the link. You can rewatch everything. And hopefully see you next time with the next webinar, because I think we can say it was a success. I think if we can do this more often, that would be something great. All right, everybody, have a nice lunch, and maybe see you in the future.
Thank you all. Bye-bye.
Bye, everyone. Thank you.
Bye.